This is a brief anatomy review of the shoulder girdle. It will include bones, bony landmarks, different joints of the shoulder, and ligaments. If you want further review of the muscles, please refer to the anatomy review that was done by Enid that is posted on Blackboard. So we're going to start with the clavicle. So the clavicle is an S-shaped bone. We have our sternal end indicated here in the image. This attaches medially to the sternum. We have our acromial end, which is lateral to the body, closer to the scapula. The mid portion of the clavicle is called the body. We know as you move laterally onto the clavicle flattens. We know that if you move more medially towards the sternal end, the medial side is more round and smooth. Believe it or not, the clavicle is one of the most commonly broken bones in the body. And in Latin, clavicle means little key. And I think this is important to note because we know that as the shoulder joint, the glenohumeral joint, abducts, flexes, does a lot of motions. There is a lot going on at the clavicle as well, so it's not a joint that we should forget. Moving on to the sternum. So we know the sternum is a flat bone in the midline of the thorax. We have the manubrium at the proximal end. This provides our attachment for the clavicle and the first rib. The body in the middle portion. This is the attachment for the middle 2/3 of our sternum, and this is where our ribs attach. And then the xiphoid process distally is our inferior component of our sternum. Looking at the sternoclavicular joint, we have anterior and posterior sternoclavicular ligaments. These attach to the manubrium of the sternum, and they are on the medial side of the clavicle, again, both anterior and posterior. And these are going to limit movement, anterior-posterior movement of the clavicle. We have our costoclavicular ligament. This is between the clavicle and the first rib, and this limits elevation of the clavicle. And then our interclavicular ligament. This is between the right and left clavicle, so superior to the manubrium, and it limits clavicular depression. So we can see with this image here, we have our interclavicular ligament. So between the two clavicles, our sternoclavicular between the sternum and the clavicle, the manubrium of the sternum, and then our costoclavicular between the first rib and the clavicle. Moving on to our acromioclavicular joint, which we know is lateral, closer to the glenohumeral joint. We have our superior and inferior acromioclavicular ligaments. These attach again laterally to the clavicle and the acromion, and they prevent clavicular dislocation, or they try to limit it. Our coracoclavicular ligaments. These are between the coracoid and the clavicle. There are two. We have the conoid, which is more medial, and the trapezoid, which is more lateral. And this prevents a lot of posterior motion of the scapula and rotation. And lastly, we have our coracoacromial ligament. This is between the coracoid and the acromion, and it serves as kind of a roof or a superior surface over the head of the humerus. So it serves to protect and provide support to that part of the acromioclavicular joint. So we can see in our image here, so our acromioclavicular ligaments here, the distal end of our clavicle and the proximal portion of our acromion, our coracoacromial ligaments, and then the two components of our coracoclavicular ligaments as well. Moving on to the scapula. So the motions that are going to occur at the scapula include elevation and depression, protraction and retraction. These are typically more linear type of motions. However, when we think about upward and downward rotation, we talk about upwardly rotating and downwardly rotating the scapula. You can also observe some scapular tilt. And typically this will occur when the shoulder is in hyperextension. So if you're extending the arm posteriorly, the scapula, the superior portion of the scapula should still tilt anteriorly, and the inferior portion should tilt posteriorly. Another thing I want to quickly review is the muscle coupling that occurs as the shoulder abducts or flexes, or we elevate the arm. So muscles that help with upward rotation of the scapula include the upper trap, the lower trap, and the serratus anterior. We know with downward rotation, we have different muscles that help out. We have the levator scapula, the rhomboids, and the pectoralis minor. So talking more about the glenohumeral joint, the primary motions that occur at the shoulder, we know flexion, extension. You will see some people document hyperextension. This is typically anything more than about 45 degrees. It may be described as hyperextension. We have ab and adduction, AB and adduction. We have medial and lateral rotation, which is also our internal or external rotation. We can have horizontal AB and adduction, and then scaption. So this is occurring in the scapular plane. So it's about 30 degrees of flexion. So if the arm is placed out to the side in an abducted position and you bring the arm anterior about 30 degrees, that's considered the scapular plane. And there's a lot of things that we will do in the scapular plane because it is more biomechanically sound for the glenohumeral joint, better articulation of surfaces. So to review some important bony landmarks for our scapula, if we look on our anterior surface, which is on the right here of this image, we have our subscapular fossa. We have our glenoid fossa, which is where we get articulation with our humeral head. We have the labrum that's highlighted in red here. So the labrum in the shoulder is very similar to the labrum in the hip, in that it is a fibrocartilaginous ring. It's attached to the rim of the glenoid fossa, but its job is really to deepen that articular cavity of the shoulder and to give more stability to the shoulder. On the posterior side of the scapula, we have the supraspinous fossa, the infraspinous fossa. We have the spine of the scapula, which terminates with our acromion process. Moving on to some bony landmarks of the humerus. So if we look at an anterior view here on the right side, we have the head of the humerus. We have our lesser tubercle, our bicipital groove, where that biceps tendon will sit, and then our greater tubercle. We know that our rotator cuff muscles will attach at the greater tubercle. So we've got our supraspinatus, our infraspinatus, and our teres minor that all attach there. Our lesser tubercle is where the subscapularis attaches. And then if we move down a little bit into the shaft, we have the deltoid tuberosity where the deltoid muscle attaches. Looking at the posterior view, again we have the head of the humerus. Again, you can still see the greater tubercle from that posterior view, and moving inferiorly. So one of the things that we will talk about a little bit more in class is the importance of that bicipital groove, and we'll also discuss that when we talk about some special tests. So on either side of that bicipital groove is the bicipital ridges, and that's kind of the crest or the lips on the medial and lateral sides of that bicipital groove. Moving on to talk about some ligaments and capsular structures. So the joint capsule for the glenohumeral joint attaches to the glenoid of the scapula and to the anatomical neck of the humerus. When the arm is at rest at your side, so just in anatomical position, we know that the superior portion of the joint capsule will be more taut, it will be tight, and the inferior portion will be on slack. So this is an anatomical position at rest. Some other important ligaments are coracohumeral ligament. This attaches from the coracoid to the greater tubercle. It provides strength to the upper portion of the joint capsule. We have our glenohumeral ligaments, which reinforce the anterior portion of the capsule. We have several components of those glenohumeral ligaments. You actually have a superior, a middle, and an inferior glenohumeral ligament. We already discussed the glenoid labrum in the last slide. That's on the glenoid fossa and provides stability and support to the shoulder. And then the rotator cuff, which is, we know, are muscles that provide stability to the shoulder. So an important point that I wanted to make about this coupled motion, we know that as the humerus is abducted, or you elevate the arm, we get a combination of forces from all of the muscles around the shoulder, particularly the rotator cuff muscles and the deltoids. As the arm is abducted, the rotator cuff muscles will provide that support and stability at the glenohumeral joint. So you can see highlighted in red here. You get a stabilizing force from that rotator cuff into the glenoid fossa, then as the deltoid abducts the arm. So that important combination does not always occur in patients that have impairments. So it's important to watch and monitor and evaluate when you are working with a patient with a shoulder injury, but something to keep an eye on. The last thing to kind of mention is all of the different muscle groups that we didn't cover. So this is covered by Enid in another anatomy review video. So if you want more specifics about muscles of the periscapular area as well as the shoulder itself, please review those videos.